It's time for another warm-up review. Let's get going. Which hormone has each of the following actions? So first we have stimulates milk production during lactation. That's going to be prolactin. What about stimulates milk ejection during lactation? That's going to be oxytocin. Stimulates metabolic activity in general. That's going to be thyroid hormone. Increases blood glucose level and decreases protein synthesis. Think of cortisol. And then stimulates ovulation in females and testosterone synthesis in males. That's going to be LH luteinizing hormone. Next, what is the rate-limiting enzyme for each of the following metabolic pathways? So first we have the urea cycle. Think of carbamoyl phosphate synthetase 1. Next we have hexose monophosphate pathway. That's going to be glucose-6-phosphate dehydrogenase. Fatty acid synthesis. Think of acetyl-CoA carboxylase. Next, we have beta oxidation of fatty acids. It's going to be carnitine acyl transferase. Ketone body synthesis, that's going to be HMG-CoA synthase. Cholesterol synthesis, that's HMG-CoA reductase. Bile acid synthesis, 7-alpha hydroxylase. And then heme synthesis is going to be aminolevulinate synthase. All right, that's the end of the warm-up. Let's get to that video.
In these final videos, we're going to be talking about cancer drugs. Now, chemotherapy drugs can be pretty daunting for a lot of students because they're really pretty foreign to you. So I'm going to try and make things as easy as possible for you because there are a few things to know that are really high yield for your exam. So as we go through these drugs, focus on the high yield details that I'm going to point out to you. And focus on what's specific to individual drugs or classes of drugs. Don't really worry about non-specific things. For instance, don't try to memorize which drugs cause myelosuppression or which ones cause alopecia or GI upset, because pretty much all of them do that. Now we can group chemotherapy drugs based on how they work. Some drugs inhibit nucleotide synthesis or DNA synthesis. Some drugs inhibit microtubules so that the cell physically can't divide, and so on. You can also group these drugs based on when they work within the cell cycle. Some drugs work in S phase when the cell is synthesizing DNA. Some drugs work in the G2 phase when the cell has already replicated its DNA and now it's preparing for mitosis. Most anti-cancer drugs are targeting rapidly growing cells, cells that are undergoing DNA synthesis and mitosis frequently. So, where are rapidly dividing cells normally found in the body? Well, the hematopoietic cells of the bone marrow, the GI tract, and the hair follicles. So, lots of cancer drugs, in addition to blocking rapid division of cancer cells, will also cause bone marrow suppression, GI problems like diarrhea, and hair loss. So let's talk about some specific cancer drugs, starting with methotrexate. Methotrexate is a folic acid analog, and rapidly dividing cells need folic acid in order to replicate their DNA. Folic acid is used in the synthesis of pyrimidines, which we've looked at before back in biochem. So you take tetrahydrofolate, or THF, and you convert it to 5,10-methylene THF, and you use that to make thymidine monophosphate. But in the process of making thymidine, tetrahydrofolate is changed to dihydrofolate. And in order to regenerate tetrahydrofolate, you need the enzyme dihydrofolate reductase. So methotrexate is an analog of folate, so it inhibits dihydrofolate reductase. So if you give methotrexate, you shut down this folate cycle, and that means you can't make thymidine, so you can't replicate DNA and the cancer cells can't divide. So methotrexate is called an anti-metabolite. And since it's working during S phase, when the cell is synthesizing DNA, it's an S-phase specific antimetabolite. Now you can also see that the antibiotic trimethoprim inhibits dihydrofolate reductase. So again, knowing this folic acid pathway and how it's used in thymidine synthesis, and where these drugs like methotrexate and trimethoprim and 5-FU inhibit this pathway, is definitely high yield. There are three main categories of clinical uses for methotrexate. The first category is as a cancer drug for things like leukemia, such as ALL or AML, for lymphoma, and then sometimes breast cancer and sarcomas and other solid tumors. The second category we use methotrexate for would be certain uterine pathologies, like choriocarcinoma, which is basically a placental cancer of the uterus. Remember, hydatidform moles are the precursor to choriocarcinoma. And then if you need to abort a pregnancy, like an ectopic pregnancy, you could use methotrexate for that. And then the third big category is immunosuppression. Methotrexate is commonly given as an immunosuppressant for things like rheumatoid arthritis or psoriasis. Then as far as side effects, myelosuppression is a big one. But again, that's pretty common with a lot of these drugs. But you do need to know that for methotrexate, the myelosuppression is reversible with a drug called leucovorin, which is basically folinic acid, which is a derivative of tetrahydrofolate. So know that leucovorin can be given to reverse myelosuppression from methotrexate. That's very important. Another important toxic side effect to know about with methotrexate is fibrotic lung disease, which is sometimes called methotrexate lung. And then also it's teratogenic. So what would you think would happen if you had a woman on methotrexate for psoriasis, for instance, and then she happened to get pregnant? What problem would you expect to see in the fetus? Well, this is interfering with folic acid metabolism, basically interrupting the function of folic acid. So you might see a neural tube defect. The next anti-metabolite I want to talk about is 5-fluorouracil, or 5-FU, which sounds a little dirty. You shout out 5-FU in the wrong neighborhood, you could get in a lot of trouble. But 5-FU is very similar to methotrexate. Instead of being a folic acid analog, 5-FU is a pyrimidine analog, which is converted to 5-FDUMP, or 5-FDUMP, which also sounds a little dirty. And then 5-FDUMP covalently binds to folic acid and inhibits thymidylate synthase. So it inhibits DTMP synthesis and DNA synthesis, just like methotrexate. So when do we use 5-FU? Well, we use it for colon cancer and pancreatic cancer, but the big places you're going to see it used are basal cell skin cancers and actinic keratosis. And we talked about how actinic keratosis is a pre-malignant skin lesion that can become squamous cell skin cancer. So to obliterate actinic keratosis, you're going to put on this topical 5-FU cream on the skin for a month or so, and you're going to kill off those actinic keratoses, and that's going to decrease the risk of squamous cell cancer later. And then for side effects with 5-FU, it can also cause myelosuppression, just like methotrexate does, but this myelosuppression is not reversible with leucovorin. Now, if you do have an overdose with 5-FU and you need to give something to rescue the patient from the myelosuppression, you can use uridine as your rescue agent. And then you can imagine with topical use, 5-FU can also cause some photosensitivity. So let's move on to 6-mercaptopurine, or 6-MP. And we've touched on this one before. 6-MP is still acting in the S phase, and it's still an anti-metabolite, but it's a purine analog. So it inhibits the purine synthesis pathway by inhibiting the enzyme PRPP amidotransferase, which catalyzes the first committed step in purine synthesis. So again, 6-MP inhibits purine synthesis. The other thing you need to remember about 6-MP is that it's metabolized by xanthine oxidase. Now, what were the gout drugs that inhibit xanthine oxidase? Allopurinol and febuxostat. So the toxicity of 6-MP is increased in patients who are also taking allopurinol or febuxostat for gout. If you inhibit the enzyme that metabolizes 6-MP, there's an increased risk of 6-MP toxicity, including myelosuppression and hepatotoxicity. There's a similar drug called 6-thioguanine. It's basically the same as 6-MP, except it's not metabolized by xanthine oxidase, so it can be given with allopurinol. That's really all you need to know about that one. There's a purine analog called cladribine, which has several different mechanisms of action. For instance, it inhibits DNA polymerase, and it also induces DNA breaks. Now, this is used for hairy cell leukemia, which is really classified as a type of lymphoma. And cladribine can cause myelosuppression, neurotoxicity, and nephrotoxicity. Now, there's another S-phase anti-metabolite called cytarabine. But instead of being a purine analog like 6-MP and cladribine, cytarabine is a pyrimidine analog, kind of like 5-FU. So you can use the C and T in cytarabine to stand for cytosine and thymine, which are pyrimidines, and that reminds you that cytarabine is a pyrimidine analog. But like cladribine, cytarabine inhibits DNA polymerase. And that's the main point I want you to know. Now, we use this drug to treat AML and certain lymphomas, and it causes side effects of myelosuppression and megaloblastic anemia. Now, we've talked about antiviral drugs that inhibit viral DNA polymerase, like acyclovir and ganciclovir. And then what's the antibiotic that inhibits DNA-dependent RNA polymerase? That's rifampin. The next group of drugs we're going to cover are the alkylating agents, starting with cyclophosphamide. So an alkylating agent is a drug that attaches an alkyl group to the DNA, and it cross-links the DNA strands so the DNA can't replicate, and that means the cell can't divide. So cyclophosphamide specifically alkylates guanine residues on DNA. It's used to treat cancer, and it's also used off-label as an immunosuppressant for things like lupus nephritis or polyarteritis nodosa. Now, one unique thing about cyclophosphamide that you definitely need to know is that it can cause hemorrhagic cystitis due to a toxic metabolite called acrolein. So cyclophosphamide is metabolized to acrolein, but if you give a drug called Mesna with the cyclophosphamide, the Mesna is going to bind to acrolein, so it's not toxic anymore, and that's going to prevent this hemorrhagic cystitis. And the cyclophosphamide also increases the risk of transitional cell bladder cancer. So there's 2 bladder-related toxicities. Then you should also know that cyclophosphamide requires bioactivation in the liver. There's also an alkylating agent called ifosfamide, which is very similar to cyclophosphamide in terms of the mechanism and in terms of causing hemorrhagic cystitis and using mesna to prevent that hemorrhagic cystitis. Now, ifosfamide is used for testicular cancer, but it's not really used as an immunosuppressant. The next group of alkylating agents is nitrosoureas. Sometimes they're called nitrogen mustards. Now, most of these end in mustine. So if you remember the phrase, put nitro in your Mustang, that might help you recall the names of these drugs. Carmustine, lomustine, semustine. Or maybe you remember that mustard gas, a chemical weapon from back in World War I, mustard gas was an alkylating agent, and that may help you too. Mustard gas was actually a sulfur mustard, not a nitrogen mustard. But just remember, mustard gas, alkylating agent, carmustine. And there's a brain association with these nitrosoureas. So these can cross the blood-brain barrier. That means they can be used to treat brain tumors. But because they cross the blood-brain barrier, they also cause CNS toxicity. Then one last alkylating agent I want to cover is busulfan. Now the unique thing about busulfan that you want to remember is that it can cause pulmonary fibrosis. Next, we're going to talk about some drugs that are technically antibiotics, but instead of using them to kill microbes, we're using them to kill cancer cells. So the first two are called anthracyclines, and they include the drugs doxorubicin and daunorubicin. Now these work by a couple of different mechanisms. First of all, they generate free radicals, which causes DNA damage. And second, they also intercalate DNA, which means they wedge into the DNA between the base pairs, and they form a tight bond, so that when it comes time to unwind and replicate the DNA, it can't be done correctly. Now, you definitely need to know both of those mechanisms for the anthracyclines. They generate free radicals and they intercalate DNA. And then here's one of those important, unique toxicities to know. Doxorubicin and daunorubicin are both cardiotoxic. They cause dilated cardiomyopathy and heart failure. Remember, these drugs are generating free radicals, and the heart muscle is especially susceptible to free radical damage because it's relatively deficient in the enzyme superoxide dismutase. So know that doxorubicin and daunorubicin are cardiotoxic. Now, one student wrote in that she remembers this by calling it cardiotoxorubicin, which is pretty clever. And then also there's a drug called dexrazoxane, which is an iron chelating drug that you can give with the anthracyclines to prevent that cardiotoxicity. The next drug is dactinomycin. It's another drug that intercalates DNA. There are 3 clinical uses of dactinomycin to be aware of. Number 1 is Wilms tumor, which is a renal tumor in children. Number 2 is Ewing sarcoma, which is a bone tumor in children and adolescents. And number 3 is rhabdomyosarcoma, which is a childhood muscle tumor. So you can remember the mnemonic, children act weird. Children, because these are childhood tumors, act for dactinomycin, and then the W, the E, and the R in the word weird are for Wilms tumor, Ewing sarcoma, and rhabdomyosarcoma. There's one more drug I want to cover, but first, let's review what we've done so far with a quick whiteboard review. Let's start by matching the drugs on the right with the mechanisms of action on the left. So the first one is generates free radicals and intercalates DNA. That's actually 2 of our drugs on our list. It's doxorubicin and also daunorubicin. The next one inhibits dihydrofolate reductase. That's methotrexate. The next one inhibits thymidylate synthase is 5-FU. And then the one that inhibits PRPP amidotransferase is 6-MP. And the one that inhibits DNA polymerase is cytarabine. Next, I've listed some drugs that you might give to prevent toxicity. So for each one of these, let's list which chemo drug you give it with, and then what toxicity it's supposed to help prevent or treat. So the first one is dexrazoxane. We said we give dexrazoxane with doxorubicin and also with daunorubicin. And we give that in order to prevent cardiotoxicity. The next one, leucovorin, we give with methotrexate. We do that to rescue from myelosuppression. The next one is mesna, which we give with cyclophosphamide. And we give that to prevent hemorrhagic cystitis. And the last drug here, uridine, we give with 5-FU, and that's to rescue from myelosuppression. And because you're so brilliant and doing such a good job on these, I'm going to give you an honorary membership into Mensa, which should not be confused with Mesna. There's one more drug I want to cover in this video, which is bleomycin. Now, bleomycin seems to have two mechanisms of action. It can bind to DNA and cause single and double-stranded DNA breaks, and it also generates free radicals, kind of like the anthracyclines did. And it may be that the free radicals are what causes the DNA to break. But unlike the anthracyclines, instead of causing cardiotoxicity, bleomycin causes pulmonary toxicity, like pulmonary fibrosis. Now, what was the other cancer drug that starts with a B that causes pulmonary fibrosis? Busulfan. So both bleomycin and busulfan can cause pulmonary fibrosis. And we also said that methotrexate causes that fibrotic methotrexate lung. One other point to make about bleomycin is that we use it as part of a cocktail of drugs to treat testicular cancer, along with etoposide and cisplatin. We're going to talk about those in the next video. But one student suggested that we can remember that bleomycin is associated with pulmonary fibrosis and with testicular cancer by thinking about Lance Armstrong. Apparently, when Lance Armstrong was being treated for testicular cancer, they decided to drop bleomycin from his regimen because he didn't want to get pulmonary fibrosis, which might have jeopardized his racing career. All right, let's pause the video and work through the end of session quiz. So the first question, how does the mechanism of action of methotrexate differ from 5-fluorouracil? So both of these drugs decrease DNA synthesis, but they do it in a slightly different way. Methotrexate is a folic acid analog that inhibits dihydrofolate reductase. 5-FU is a pyrimidine analog that complexes with folic acid, so it inhibits thymidylate synthase. Next, how does the body metabolize 6-mercaptopurine? We said 6-MP is metabolized by the enzyme xanthine oxidase. Next one, which anti-cancer drug is also often used in rheumatoid diseases as well as ectopic pregnancies? Methotrexate. And the last one, which anti-cancer drug fits each of the following descriptions? So the drug that alkylates DNA and then toxicity results in pulmonary fibrosis is busulfan. The one that fragments DNA and also causes pulmonary fibrosis is bleomycin. Blocks purine synthesis and metabolized by xanthine oxidase, again that's 6-MP. Nitrogen mustard that alkylates DNA, those are the nitrosoureas, like carmustine and the others. Folic acid analog that inhibits dihydrofolate reductase, we said that's methotrexate. Intercalates DNA, producing oxygen-free radicals, and is cardiotoxic, that's doxorubicin and daunorubicin. DNA alkylating agents used in brain cancer are the nitrosoureas. Applied topically for actinic keratoses and basal cell cancers is 5-FU. Treatment for childhood tumors, that's dactynomycin. And then side effect of hemorrhagic cystitis is going to be seen with both cyclophosphamide and ifosfamide. That's it for now. You're almost to the end. I'll see you next time.